Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and the title of tonight's webinar is Demand More with BIMZELX Transformative Results in Hidradenitis Suppurativa. As moderator this evening, we have Dr. James Del Rosso. He is Research Director, Principal Investigator at JDR Dermatology Research, Las Vegas, Nevada, Adjunct Clinical Professor, Dermatology, Touro University, Nevada, in Henderson, Nevada, and President, American Acne and Rosacea Society. As speaker this evening, we have Dr. Brad Glick. He is member of the AAD Board of Directors, Residency Program Director at Larkin Palm Springs Hospital, and PI GSI Clinical Research, ASDS Advocacy Ambassador in Miami, Florida. We would like to thank our supporter this evening, UCB, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and it will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this short survey. And lastly, within 1 to 2 days of the webinar, you will receive a certificate of attendance. It will be emailed to you. Now, without further ado, I would like to pass the floor virtually to Dr. Del Rosso.
Thank you, Ashley, who does such a great job getting this all started for us. And my name is Jim Del Rosso. I'm a research director and principal investigator at the research center we have here in Las Vegas, Nevada, and also have an adjunct faculty position at Touro University. And it's a pleasure to be doing this with Brad Glick, who we'll get to in a little bit, but the International Dermatology Education Foundation, for which I'm the stunt double tonight for Dr. Leon Kircik. He is really the one that initiated this idea and is really the president of the IDEF, and it really has done a great job at having a variety of educational programs really raise the awareness related to dermatology. And here are some of the previous educational sessions. There are many of them with many different presenters. And next slide. And how you can stay up on this, these are some of the platforms you can go to. You see them here, that you can access this information, and visit the website www.idefeducationalseries.com to register for upcoming events. They really are very, very good, and they're very consistent. So now I am very, very happy to introduce someone that I've known. Brad, it's been too long, many years, both in working with the DO Dermatology College and actually both serving together on the board of the American Academy of Dermatology for a while. The slides are moving faster than I'm speaking, so I don't know exactly why that's happening. They may be on some kind of automatic feed, but I hope they're not. But Brad Glick is a great guy, does a lot of clinical research, a lot of clinical practice, and has done a lot of hidradenitis suppurativa trials. And with bimekizumab, I've done the same and actually was involved with those trials for hidradenitis, which some of them are currently ongoing. So Brad, take over and we'll have some great discussion about an extremely important topic for a disease that is miserable for people that have it, as you know.
You know, you stole my word. That's how I call this disease. I call this disease a disease of misery. And, you know, first of all, thank you to you and to UCB, to RBC Consultants, and to IDEF for really putting all this together. But this is a very important topic. And I see what's happening in hidradenitis suppurativa as kind of one of our newer waves. We finally have some stuff for these patients. We had our first biologic about 10 years ago in adalimumab, and another agent that came in the last couple of years, but now we can demand more with BIMZELX. For the audience, you can see this word transformative, and it really is true. And Jim, I think tonight, one of the things we're going to be able to demonstrate is a story that we've actually told already in this last year. It was quite a delay in BIMZELX coming to market for psoriatic disease. And then seemingly like overnight, 5 approvals. Psoriasis, psoriatic arthritis, ankylosing spondylitis, non-radiographic axial spondyloarthritis, and now hidradenitis suppurativa. And for the audience, remember the word transformative, because this therapeutic is transformative. And in the transformative word are two key inflammatory cytokines that we know play a critical role in hidradenitis suppurativa, and that's IL-17A and IL-17F. And so we really should demand more for our patients, and we can actually accomplish that with BIMZELX.
You know, Brad, with the trials, it's going to be, I think, important to point out some of the distinguishing features that actually have come forth in the clinical trials with BIMZELX, even, you know, for hidradenitis, and how some of the targets, the outcomes were put. So, you know, I think we'll, as we go through it, people are going to see that it's not purely to promote, it's information that is actually well substantiated.
Yeah, I love this deck because it really talks about the disease itself as we look at the data. One other thing that's really important is that we're not just going to talk about clinical responses, we're going to talk about how the patients felt. And before I move on, I think it's really pertinent. In clinic on Wednesday, well, just yesterday, I had a patient who was a potential clinical trial patient, and Jim, I walked in the room and she was standing, and I said, why don't you sit? And patients with HS don't want to sit down a lot because they're in pain.
Right.
And I think their feelings of pain, their discomfort, the drainage that they have makes this that miserable disease that you referenced. And so I'll dig in. The disclosure is here. This is promotional, sponsored by UCB, and I'm compensated as a speaker. And certainly we're going to stick to the label in this educational program. And what I think that we will all enjoy most is the ability for Dr. Del Rosso and I to have some conversation back and forth about this very important disease. And, you know, we used to call this disease acne inversa, and there's a lot of reasons why. You know, it happens very early on. We see this in our adolescence. It's miserable for these people. Genetic disease, likely autosomal dominant, significant nodule formation, usually in areas that are follicular, abscesses, tunnels. The physical manifestations of this condition certainly translate into what we're going to discuss in terms of what the patients report, not only how they feel, but hopefully when they receive therapy, that they have improvement of their pain and their drainage. And once that improves, the improvement of the odor. And then, you know, these patients that are early 2s going into 3s and they have scarring, their range of motion can be restricted. And that's really awful for these patients.
Pat, if we go back to that prior slide, I think there are a couple of things that are really important when we look at these textbook pictures. And, you know, we go by early stage where they can have inflammatory nodules and abscesses with no scarring or sinus tracts. When you get to early stage 2, early stage 3, you have scarring and sinus tracts. But early stages were developed for a way for us to separate these diseases. Early stage 3 is much more diffuse involvement in the areas that are involved, and they typically have more than one area. But one of the things that's pointed out in the literature that's so important is the delay in diagnosis. And that's because if you look at in the middle, and if you didn't have any of the other lesions around it, that initial lesion could easily be thought of as an abscess or an inflamed cyst that goes to urgent care or the ER or even to a dermatology office, and not necessarily thinking about hidradenitis suppurativa. So it's important to look at some of the areas that may be involved and looking for those, you know, double and triple-headed comedones that could be a sign, or some old scarred areas or something that will let you know earlier, because the earlier we treat this with therapies that really make a difference, we stop what's happening underneath, so we don't see what we have on the right with sinus tracts and tunnels. So earlier treatment is so important, I think, here.
Yeah, and we're going to hit that in some respects too, because unlike psoriasis, where we're still trying to figure out progression and blocking progression of disease and progression to psoriatic arthritis, there is data to support treating early will block the progression of this disease for sure. You know, And there's this kindred in Olmsted County, Minnesota, that I know you know, Jim, and that's where we were able to determine these populations that the average delay in diagnosis is like 7 to 9 years, and it's awful for these patients. And they progress so badly. By the time we see them, a lot of the times they have permanent injury.
And the sequelae, scarring, fibrotic sinus tracts and tunnels, that's not reversible at that point. You have to stop it earlier, right? And that's such a big part of what we're talking about. But don't want to hold you up, but
no, all good, all good. It's great, great. I love this part. So, you know, the physical manifestations we've just talked about, and one of the things I led with is it's not just so much even how this condition looks, but how the patients feel. And we'll talk about the HS squall a little bit later on. Here's an individual who's 38 years old. She's had HS for a really long time. And just listen to what some of these people say. I have made career choices and avoided greater work responsibilities to accommodate my HS because I cannot have others relying on my ability to work. I mean, that is profoundly impairing an individual's activities, daily living, their life, their work. This impairs sexual performance, relations with people. It's a miserable, miserable disease. And there are specific symptoms that these patients have: pain, discharge, itch, odor, psychological impact, emotional contributions.
Sexual performance, I mean, a lot of them don't even get to the point where they could even perform. They're so embarrassed that they don't even get into intimate situations, understandably, depending on where the lesions are. So, and they have this every day. When they come in and see us, a lot of times they're trying to be nice and, you know, smile and be friendly. But the bottom line is, after they leave our office and we're on to the next person, they're dealing with this every day. And just think about that. So we can really make a difference.
We can. And the areas of involvement translate so significantly to these psychological impacts and the impacts of daily living. I mean, so there's a negative impact on quality of life for sure. So what are the goals based on what we just discussed? The clinical manifestations of HS, the abscesses, the tunnels, preventing scarring. What do we hope that our patients can gain from proper therapy and satisfactory responses? And how do we grade that? Pain reduction, improvement of quality of life, just overall effectiveness of the therapy. As Dr. Del Rosso just said, trying to prevent that progression of disease. A therapeutic that will have not only long-term benefits, sustaining responses over time, but also the long-term safety. And, you know, it says here, Jim, avoidance of surgery. And certainly if we can do that with a singular therapeutic, that's great. But I think you would agree, this is a disease state that requires a lot of co-collaboration therapeutically, and certainly requires a lot of collaboration with our colleague surgeons, our rheumatology partners, GI, et cetera. What are your thoughts?
Well, the thing about surgery is, when we used to talk about surgery for years, it was a radical dissection and removal of the entire axillary area of involvement. There are surgical interventions now, like de-roofing and other modalities, and even intralesional corticosteroid therapy. You're not talking about 2.5 milligrams, 5 milligrams. You're talking about 20 to 40 milligrams per cc injected into a deep area. And one of the things I wanted to ask you about, disease progression, there are two factors. Anxiety, depression are very common psychological comorbidities. So we have to think about ways that we're not necessarily sitting down there to do that, but get the patients the help they need beyond just a handout. But smoking and being overweight, you know, when you look at the BIMZELX trials, the BMIs were high. Most of these patients were in the would be considered in the overweight obese category, and which is common, and very commonly they were smokers. And those two are tied to progression and severity of the disease. So how do you, in a busy clinical practice, you're not at a place where down the hall you have somebody to handle each area that you need to get the patient to. How do you deal with those aspects of the disease before you're thinking about the therapeutics?
Yeah, I think that, with the advent of what we learned in the last 20 plus years from our understanding of psoriatic disease and inflammatory cytokines and what have you, what we've also talked about is all of those background comorbidities because they impact therapeutic response potentially. So I do take some time to discuss certainly two of those factors too. One is weight reduction. It's challenging for these patients. You can't just say, well, let's lose weight overnight and exercise. Right. So I don't make it the first part of the conversation. And I might get into it, Jim, really in the second visit.
Yeah,
2 weeks later, a month later.
You're not going to hit them with everything on the first visit, exactly. But it's important to realize if you intervene and they lose some weight and they stop smoking, their disease will often do better.
Right? Yeah. And we have data clearly that weight reduction helps these patients too. And of course, we're starting to see some data as well in the world of these patients that also have background diabetes. They're obese. They're on GLP-1 agonists, and their HS may improve as well too. And we see from this comment here, and I think as we have this discussion, clearly what we're hearing, Jim, is that we have a significant unmet need. And what we see here is the disease at the beginning, it's somewhat quiescent, early disease. If we manage it, we can block, we can level it off. We don't have to necessarily have high peaks. If we have high peaks, we may not get to those valleys. And what we see with patients is that if we don't treat early, these patients may have functional impairment. And as well, there'll be that critical point, as you said before, when you have that, if we look at early stages as one way to assess these patients, and we go from just inflammatory changes with some abscesses and nodules, some draining tunnels, and then we start to see that early scarring. Now we have a risk of permanent injury, functional impairment, inability to move arms, inability to have appropriate relations, just as you said before. What else are your other thoughts about the significance?
The way I look at it, that first one, the gray lines that are going up and down, just like the early stages, that's us assessing disease visually, which is how everything is done in dermatology, not thinking about what's going on underneath. But in the valleys there's still inflammation going on underneath that's still leading to disease progression before you get that next peak. So it's like you're waiting for the volcano to explode before you understand that something was going on underneath. And if you carry it forward, if we intervene, it's really, there's going to be an argument against as soon as you diagnose HS, everybody gets a biologic. I understand that. But at some point, you're going to have to make a determination that we want to shut off that last part, that disease progression and irreversible damage, because that's what lies beneath. And that's why if we wait for them to get to well into early 2 and early stage 3, that's like treating end-stage renal disease or almost at end-stage. It's too late. It's not necessarily too late, but you didn't stop a significant portion of the disease, right?
I think another important point too is this is not just the clinical inflammation that we see that is then represented of these inflammatory cytokines that we're going to talk about in a couple of moments. All of them, TNF, IL-17. It's also the perilesional skin. These patients have inflammatory burden that is well beyond their clinical disease. So that brings us to BIMZELX, the first and only approved biologic to selectively target overly expressed IL-17A and IL-17F cytokines in moderate to severe HS. And as we like to comment, while we have significant understanding, we've learned so much great work in HS, understanding the inflammatory cytokines by Jim Kruger and colleagues at Rockefeller. We've learned so much. We see a lot of similarities in the inflammatory burden with HS and psoriatic disease, for which we've learned so much this last few years. But there are certainly some differences in the way this disease presents. Follicular occlusion, dilation, blockage, expansion of the follicular apparatus. This is why we see this early on in adolescence, which is why, Jim, we also, not just treating early disease, we need to get to these kids early on because they'll suffer and they'll progress. And as you said before, what's also critical is hoping that, and I think part of the education as we have this HS wave is to make sure that our colleagues just don't look at every abscess or boil as just that, because these patients may have HS. They have a significant inflammatory burden that is driven by Th1 and Th17 inflammatory cytokines. And we know, and we'll discuss this a lot, that we have high levels of IL-17A and even higher levels of IL-17F, tenfold from what we know in terms of the inflammatory response in these patients, and the disease progression and the tract formation and irreversible damage is just what we were talking about as these follicles that become chronically inflammatory. They coalesce, and this is how we get this purulent drainage. We get these sinus tracts, these tunnels that these patients have. What are your thoughts about this?
What's interesting, though, with so many disease states, whether we look at AD, psoriasis, even acne, we have these models where we have, arrows pointing to this, then progressing to the next thing, and certain things going on simultaneously. We don't have that nearly as nicely drawn out with HS, where we still have some gaps in our understanding of how some of these things connect together. How does occlusion of the follicle lead to this underlying inflammation that we see diffusely in the tissue, and then areas where there may be fibrosis and other areas where they're not? And that's why I think it was such an advance to get beyond just the TNF inhibition and seeing how important IL-17 was in the whole process of more significant inflammation. Because with the anti-IL-17 agents, because we have one that's 17A alone that's approved, now we have the 17A and F, I believe we are seeing a substantially, there's not a comparative data, but I'm observing as this being a major impact on the disease state with anti-IL-17.
Well, there's no question we have an inference of what you just said in some of the data that we have from the psoriasis trials as well. So let's go ahead and move on. It doesn't seem like my slides are moving now. There we go, great. So we know that IL-17F, let me just back up here. It looks like we have a little bit of issue here going on. There we go. Let me just move that forward.
Okay.
Okay. There we go. A little delay there. So we know that IL-17F is one of the significant key drivers and overexpressed 10 times more than IL-17A. And one of the things we also know, as we saw in the psoriasis trials, is that certain blockers of interleukin-17, like IL-17 inhibitors, they block IL-17A, they block IL-17AF, but they don't block IL-17FF, as we'll talk in a couple of minutes. And so I think what we've learned is that we know that there are tenfold higher levels of IL-17F compared to IL-17A in patients with HS. And as I was saying before, Jim, the story is somewhat similar, because we told this previously when we were having our discussions about psoriatic disease. It's a very similar discussion, because it's critical that we understand that there are certain inflammatory cytokines for which there are more significant targets. There are dimers, AA, AF, and IL-17FF, that all bind and activate to the IL-17RA and C receptor, further driving this cycle of inflammation. And we've learned this from in vitro studies as well.
All the cytokines play a role. So if you can block more of them, that stands to reason that is something that is going to be favorable to do, and it turns out that way.
Yeah, absolutely. But I think one of the things about this drug, we think, because of course we can understand it from in vitro data, but then we have to potentially say that the clinical relevance is not necessarily specifically understood. But it seems from what we know that by inhibiting specifically IL-17F, but IL-17FF, this other dimer that probably is not hit as effectively, if at all, by specifically IL-17A inhibitors, may in fact explain the profound responses that we may see in certain therapeutics, like we see with BIMZELX, and as we saw in the clinical trials for psoriasis.
I don't think there's any doubt about that. All of these dimers play a role, and the only way you're going to block FF is by doing that. And just the same, remember, it's not all IL-17, any of these is not all IL-23 dependent, right? Because there are other cells that produce IL-17, including all these dimers. So being able to actually block all of those dimers makes a big difference. Now, we don't have the direct comparative data with HS compared to the other agents like we do, very robust data in psoriasis. But I do want to point out the dosing for HS is greater than it is for psoriasis and certainly psoriatic arthritis and axial spondyloarthropathy. It's the higher dose, 320, just like moderate to severe psoriasis, 320 milligram injection, but it's more frequent. It's every 2 weeks, then progressing to every 4, where the psoriasis is every 4, progressing to every 8. So we need more of it because this disease has potentially more areas of involvement and tougher access in these deeper inflamed areas.
Yeah,
right?
I was just going to say the same thing.
Right.
Yeah. I mean, different disease states, different, similar thinking, but different disease states, because our target is different. Our target is definitely different. And really, this is saying much of the same thing. Once again, by blocking IL-17FF, in addition to ANF and IL-17AA, we provide this, profoundly impactful anti-inflammatory effect. And I think it's fair to say that in this IL-17 inhibitor, we have a more profoundly targeted therapeutic in terms of its performance and its at least presumed mechanism. So let's look at some of the trials, some of the data. Now, I alluded to this before, over 40,000. I think right now the number is probably closer to 41,000 individuals treated with BIMZELX worldwide, 11 phase 3 and phase 3B clinical trials. I mentioned the indications. Now there are 5. We didn't have a drug until about a year ago for one disease state, and now we have 5 disease states. And for me, what's important about knowing that is, to me, it speaks to safety. I think the FDA is a very challenging organization, and when they approve a drug in 5 indications and with 3 more or less simultaneous approvals, with the arthritis approval, with the ankylosing spondylitis approval, and the non-radiographic axial spondyloarthritis approval, to me it's important because it speaks to safety. And we're also going to have the ability to reach patients with severe, like hidradenitis, our patients with moderate to severe psoriasis who are adults, for candidates for systemic or phototherapy, like we see in the psoriasis and psoriatic arthritis trial.
And right now, all these approvals are in adults, so the patients are 18 years of age and older. But there was so much data collected going into the psoriasis approval that, and a lot of those other studies were already in motion. We've been in the hidradenitis Suppurativa trials with BIMZELX. We're in a very long-term trial now. I still have patients. All of them are getting the drug because they're in the longer-term open label, and none of them want to stop it. I can honestly tell you, none of them want to stop. And before the drug was approved, and they were thinking, I always had to tell them, don't hold any information back because you're afraid I'm going to stop it. I have to know what's going on. And now when they're coming in, I say, look, if anything happens, though nothing's been happening, fortunately, if anything happens, the drug is available. They're like, oh, great. But, so far, I have to tell you, everybody's coasting along and they're extremely pleased with their results. And they had significant hidradenitis suppurativa from the beginning. These people were Hurley 2 to 3. They had anywhere between 3 and 4 draining tunnels as far as the mean, and at least 16 abscesses and nodules, right? That was on the average. So these people had significant disease, and now they're like coasting along and they're smiling. They weren't smiling before, Brad. I can tell you that.
In your experience in having done the trials, we're used to 17 blockers in the psoriatic disease space working quickly. Did you see these patients turn around pretty quickly?
I would say that, in the beginning, we don't know who's getting the placebo. We don't know who's getting the active. And they had to start, they studied different frequencies to come up with the indication that they finally got, the every 2 weeks with 320 going out to week 16. Then you can go to every 4 weeks, which is the most frequent administration and the higher dose, because the psoriatic arthritis, if they don't have moderate to severe psoriasis, is 160 milligrams every month, right? So it's a lot lower, but there's a lot less areas to hit with joints. I mean, when you think about it in terms of what you're actually treating, like you said earlier, but these people would come in and notice a difference within the first few months. Definitely would notice it. The majority of them. There are ranges of response, but these people were extremely happy with their response. The ones,
You know, the interesting thing is, even with the dose frequency being different than what we're used to with psoriatic disease, right? So we're going to go, you know, with the standard dosing regimen, but then we're going to break from every couple of weeks to monthly instead of monthly, to, you know, to further along the way. You know, I think that, like we said before, just even from a immunological standpoint, with this being a deep-seated disease, we really probably need to saturate those receptors a little bit more aggressively. So in terms of,
when we get to the results, which you're going to get to, when we're
sure,
talking about 50% reduction of that Hidradenitis Suppurativa clinical response score, which is the measure that's used that we're talking about here, we're seeing patients with 70% reduction, 90, even 90%, even 100 that were measured in these trials, which is extremely important. Think about where they started and think about where so many of them are getting, right?
no
It's
question.
worlds apart.
And we've raised the bar. You know, in this trial in particular, we've had the discussions of high score 75, 90, and 100, as you said. And the high score for the audience is an assessment of that percentage reduction in the abscesses and nodules. And Dr. Del Rosso alluded to the high volume of lesions that these patients had throughout at least 2 different areas. But the critical issue with the high bar component of the high score is that there's no increase in abscess and in draining tunnel counts relative to baseline. So we see a picture on the left here, pretty profound hidradenitis suppurativa. Looks like a Hurley 2-3. There's already some scarring. There's nodules. There's abscesses. You see 50% reduction in the picture in the middle, and then complete resolution all the way out to the right, where it almost looks to me, Chip, like there's improvement of the scarring. It seems so hypertrophic.
Yeah, it's hard, you know, it's hard to tell how much is the inflammation, but
Yeah.
what's so important here is what they're actually measuring here. And a lot of this came from work by Alexa Kimball, because when they were looking at how to develop this high score compared to global assessment, there were quite a few papers that were published. I remember JEADV, she had one, British Journal, and there were some others that looked at how this high score helps as compared to just the visible global assessment and utilizing just the Hurley scores. And you get more consistency with the same rater and between raters when you're looking at each time point in the study. So that's important. But if you think about this, Brad, what they're saying is no matter how much you reduce your abscesses and inflammatory nodule counts, we're not allowing, if the patient had 8 abscesses at baseline and now they have 9, but everything else is doing a lot better. But those 9 lesions are not necessarily in the same place. They're happening in maybe in different locations. They want to make sure that not only are you treating what's present, but you're stopping new lesions from forming by putting in that with no increase in abscesses and draining tunnel counts. So think about what you said. It's getting to other areas surrounding what you're visibly seeing right now, which is such an important point. I recommend everybody listen between the lines of what Brad Glick says, because it's always brilliant. It's always brilliant, right?
But I will tell you that what you described with the individual having 9 abscesses, but everything else looks great, that's a non-responder. That's a
Right. That's
non-responder,
right.
and it's,
That's the
you know,
point.
it's confused the data. Which, speaking of the data, let's go ahead and look at rapid results. With the dosing of BIMZELX, we have about 22% of patients achieving a high score of 50 as early as week 2, increasing to about 60% at week 16. Now, week 2, we're looking at this more or less numerically as opposed to statistically. But the important point to me, Jim, is the delta, the separation between treatment group and the placebo response, which is generally flat in the first month. It rises up a little bit. A lot of these patients will be using local care and what have you, but the delta of just about 60% of those subjects achieving a high score of 50 at week 16 is really a profound response for these individuals. And remember, the dosing regimen, as we see here, it's 320 milligrams every 2 weeks as opposed to monthly we see in psoriasis. And then those individuals crossed over to every 4 weeks. We also had an every 2-week dosing arm in a continuum in those individuals that crossed over from placebo. There was a 320 milligram dosing arm of every 2 weeks as well.
So, but the thing is, this, as I was saying earlier, some of them kicking in, you're looking at 2 out of 10 reaching the primary endpoint. The high score 50 is what has typically been used as the primary endpoint. But a lot of people feel, hey, you know, that's great, but we want higher than that. And you're going to see that we get to that. That's within 2 weeks. And a significant number of them had significant pain improvement as early as week 2. That's very encouraging. Some are going to take longer, as you see, but it keeps marching up. And at week 16, it hasn't plateaued yet.
Yeah.
So
yeah. You know what? I love the reproducibility of the data. We're going to see it in a couple of moments, but I just, you know, I can't help but thinking, I know we're talking about one disease state, but I see similarities in how the patients are responding here in an HS trial as I think about those individuals when we looked at the data for plaque psoriasis. So, you know, here's an individual baseline disease. This is a gentleman who says that besides the constant pain, every day was a battle with stains and bandages. I could wear clothes, only dark colored clothes, 29-year-old with living with HS, terrible. Here's a clinical photo of baseline, an individual with an abscess and nodule count, draining tunnels of about 3 just in one location. You can see the areas of the draining tunnels. And as we look to the right, individuals in the clinical trial, this being one example of an individual, we see this profound reduction in the inflammatory response. And Jim, we can actually see the draining tunnel no longer being a draining tunnel, at least
right.
in my view as a principal investigator, where you now see the non-draining tunnel, the resolution, the improvement of the erythema as well.
Also, it's important, you could say, hey, at baseline, the abscess nodule count was only 1. That's at that point in time. That's not telling you nothing's happening underneath, that a month later or two later, you're going to have 3, maybe 4 or more. But the fact that he has draining tunnels already tells you how much has been going on underneath. Right?
No question. No question. So let's look at the data, dig in even a little bit further here. It's really nice to see what happens in a couple of weeks. These patients have had disease for a very long period of time, generally in the clinic, in clinical trials, as we see here. Here's the data to the left that we've already seen in the first 16 weeks. These are observed cases, but what happens over time? What happens from week 16 all the way out to week 48? And we're talking not only about those individuals who are treated therapeutically and carry from 60% of the individuals treated achieving a high score of 50 at week 16, but 81% in these observed cases achieving a high score of 50. And then if we look from the placebo group out to week 16, look at the capture that we have from week 16 out to week 48 in these individuals who have been BIMZELX 320 every 2 weeks, then crossing over to receive it just monthly. And we look at the placebo arm here, and these individuals catch up quite quickly because they have to have the opportunity to catch up and receive those every 2-week doses like those individuals that were receiving therapy received in that first 16 weeks. And so we have 71% of the subjects in the trial achieving a high score. of 50 at minimum. And some of these individuals who we'll see in a couple of moments when we look further into the data achieved even higher scores.
But that 71% group was not getting the active drug for the first 16 weeks.
Absolutely
so they
not.
only got
They were a
active
crossover.
for 32 weeks, right?
That's right. And they had a crossover. And so I think the catch up is remarkable. And if we look just from week 16 to week 24, and we look at those 8 weeks, we can really see how these individuals catch up. They do. So when I was asking you before how the drug works, it looks like it works fairly quickly. Very different disease state than psoriasis, because we would expect that this is a more significant burden for these patients, but the numbers speak for themselves.
I don't want to tell everybody. I rather underpromise and overdeliver. Some take a little longer. I don't want them to want to pull the plug, right? Because they're not one of those 22%, you know, at 2 weeks, right? And so you need to give it with all biologics. I don't care which one you look like, even Janus kinase inhibitors, so, you know, for certain diseases, you have to give some of the patients more time, right?
Yeah, I have a rule, and the rule is I don't pull the plug for at least 4 months, but likely 6 months for most patients. You know, we've got tons of drugs in the toolbox, and it's tempting to switch, and I agree completely.
Yep.
And so if we take that data, if I just back up for a second, and I really should, which are observed cases, and then we jump forward and we look at the same data, because a lot of times we get asked, well, it's observed cases. It's not a rigid statistical analysis. But if we look at the long-term data, we see the control period to the left, and then we see the crossover period, for instance, for the placebo. The numbers don't really drop as significantly, Jim, in a modified non-responder imputation, which is now a much higher bar because there's not that flexibility for deviations in the protocol. See with as observed cases. What are your thoughts?
I think that's important too, but I want to point out in these trials, if you weren't just allowed to change or give patients antibiotics on or off during the trial. They could have been on some stable antibiotics for at least a month before, and they could stay on that same dose. You know, about 1 out of 10 had concomitant antibiotics, but you couldn't say, oh, now I'm going to switch from doxycycline to minocycline or make changes. But there were some patients that had previously been on, were stable on it, they were allowed to continue, but that was the minority. If you had to start giving them rescue with different antibiotics, then those patients were not considered responders. So you're really looking at essentially what the drug is doing for these patients in and of itself. Also, about 2 out of 10 had previously been on biologics. That was likely going to be adalimumab, obviously, because that had been approved. So some of them did have prior biologic therapy in the past. Right?
Absolutely. And some patients exceeded high score 50s. We alluded to before, reaching high score 75, high score 90, and high score 100. And if we look at week 16, the numbers are reasonably impressive, with 17% just by week 16 able to achieve 100% clearance of their HS. If we look out to week 48, 81% high score 50. We talked about that before. Again, this observed cases, but we start to then raise the bar. 60%, getting close to almost that 2/3, but 60% of the subjects with 75% improvement of their HS. 42%
look at 90, which is practically completely clear. You have almost 1 out of 4 people within 4 months that started with the extent of disease that we're talking about, which is pretty significant. That's very impressive. I mean, it's very, you know, when I'm trying to translate this to what I've seen, at least in the patients we've had in the HS trials, and it's very, very consistent.
Yep. And you can see from the data and the design of the trial how and why the dosing regimen ended up the way that it did.
Right.
Every 2 weeks, then monthly dosing at 320, as you alluded to before. So as we look at the patient's experience and we look at overall symptom relief, we have 77% mean reduction in baseline inflammatory lesions count all the way out to week 48. And that's very, very broadly looking at these reductions in those abscesses and nodules overall. Just another way of looking at this, in addition to the high score data that we just looked at. More important, there were no new draining tunnels. 90% of the subjects had no new draining tunnels at the end of that benchmark period of 48 weeks.
So what does that tell you, right? Draining tunnels come up from underneath. Once again, you are controlling the disease, not only the areas that you saw where the lesions were, but in that those regions of involvement. You're shutting down the underlying progression of the disease and the development of lesions in the majority of the patients. That's they never had that before they ever came in and got therapy.
And to me, Sergeant, you know, to me, what this speaks to is that it may reduce my need to jump in and do surgical procedures if they have that such a profound response. So, you know, counter to what I said before was us looking at this as the disease state that requires, you know, multidisciplinary care and certainly the need for surgical intervention. That kind of data really speaks to the fact that these patients will walk into our clinic and say, oh my God, I feel so much better. And another example here, this is an individual, as the years have passed, I progressively got more bumps and abscesses anywhere the skin met skin, like my inner thighs, buttocks, under my breasts, 23-year-old suffering with this condition. And to the left, we see this baseline, the abscesses and nodule counts in this region at 5 with no draining tunnels. And as we look to the right, yep.
So this patient is a perfect, she's 23, and you're seeing her at a snapshot in time and say, oh yeah, we can get these nodule counts down. And but think about what she's telling you. Over time, it's getting worse. And then looking at whether she's a smoker, what her body weight is, you know, and if you intervene on those other areas, along with initiating an effective therapy like this early on, you'll slow down the progression of the disease and you'll totally change her life from happening to what she's describing. That's the value of this.
There's no question. And it
hard to imagine that. Somebody as old as I have never seen any patients with hidradenitis get much better over time with all the things that I was doing. This is, I'm not a buzz phrase person, but this is life-changing. Absolutely life-changing.
Yeah, so impressed with just my clinical impression when I look left to right, just profound reduction in the inflammatory burden, the lesions themselves, these abscesses, these nodules, significant reduction, and there's even reduction in the post-inflammatory changes, the inflammation, the PI, the post-inflammatory erythema, and even some of the pigmentary disturbance that you see from the patient having those lesions for a very long period of time, at least through my lenses, is significantly improved. We'll talk a little bit before we jump into safety towards the end. You know, about more than 90% of the patients report that pain interferes with their quality of life. And this is called the HSSQ, which assesses the pain severity associated with HS. So it's 4 items: skin pain, itch, smell, odor, drainage, or oozing over the past 7 days. That's, you know, we're used to these numeric rating scores, like numeric rating scores for itch. And there's the scale: 0, no symptoms; 10, the symptoms being about as bad as they possibly can be. And this is really important. You know, when we look at the therapeutic, we look at the design of the trial, and we look at the data that we saw with those improvements in the high scores, that's great. But what about how it translates to that pain, that individual I described before who doesn't want to sit down in my clinic because they're in profound pain? Now, if we look at the individuals at baseline, those who had none, mild pain, a score of 0 to 3, or those who had moderate to severe pain, 4 to 10. If we look over time, even those individuals with none or mild pain at baseline had profound improvement, 64% improvement of their numeric rating scores for their pain in those individuals who are in that mild group. Now, if we translate over to the moderate to severe individuals at baseline, what we want to see there is that their pain plummets over time in terms of its improvement. So 81% having moderate to severe pain at baseline, After week 16, it's cutting by 31 percentage points and then down to 36% in just 48 weeks. Now, Jim, we can't completely clear the pain, but when we can get those individuals that are 9s and 10s and get them all the way down to 4s and 5s, and they have these multi-grade grade improvements in their pain, they can now sit down in our clinic. What are your thoughts about that?
Yeah, these people are having at least a 3-point reduction or greater in their pain. And here, pain is a significant factor, and seeing a significant reduction in pain is important. And the consistency of them having pain, having it every day versus periodically, once in a while. And sometimes if they've already had some scarring and fibrotic areas that were there that aren't necessarily going to change with the treatment, those themselves might be a part of that persistent pain. If we could have prevented that, in my mind, I'm thinking it would do even better. I'm a real proponent for earlier treatment of HS to shut down the disease.
And this is another reason why 2 times fewer patients reported moderate to severe pain at week 48 compared to baseline. And I think, as we talked about in the beginning, improving that pain is significant, as is BIMZELX being the first and only approved therapy that actually measures quality of life through the high squall score, which is a very, very detailed scoring system from a quality of life perspective, looking at symptoms of itch, pain, drainage, odor, psychological impact, depression, like you talked about before, Jim, anxiety, which is high in these patients, significant. It makes me think of our psoriasis patients, but on the other hand, much more significant in patients from a psychosocial and psychological impact, their ability to concentrate, sexual desire, and their activities of daily living impaired, as you see here. This score from 0 to 68, none up to 5, mild, moderate, severe, or very severe. And these individuals, their mean was 24. That means that they had the number of these individuals had more severe scores at baseline, right. 24 being the beginning of severe.
They were of the very severe, being the beginning of the very severe. The other thing is, it's so specific for HS, which is something that was real. I mean, watching these people in the separate room filling out these quality of life surveys specifically for HS in all these areas was sort of going back, watching us in the room taking the MCATs. Everybody sitting there, concentrating. I mean, these people really were asked much more detailed questions than you'd get from just a DLQI. Far more.
No question. And here's that 24, the mean in getting into that, just the beginning of that very severe impact on quality of life, and very different than the DLQI, Jim. I mean, this covers so much more than the DLQI does. And we see this improvement as early as week 4 with the mean change in this high squall total score over time from 24 down to 17, week 16 down to 14, so a 10-point improvement of that high squall score, and then going by double, that mean score going down by double, down to mild, much more acceptable, with a significant impact of quality of life week 48.
So I'm looking at from baseline to week 16, right? 4 months, you went from just getting into that very severe down to mild. That's a significant reduction, right? When you just look at it numerically, you correlate it with the rating of what that is, what that actually is. They're substantially better, especially when you've been with them and seen where they started.
Right? Yeah. Thinking about symptoms, thinking about impact on quality of life, and then that psychosocial component, the depression, the anxiety, certainly impactful for these patients. And speaking of impact, we have really demonstrated how well BIMZELX can work. Looking at the high scores, able to achieve close to 30% of the subjects clear complete resolution of their HS by their high score 100. But what about safety? And I think as we look at the safety, to me, again, somewhat reminiscent, although the disease states are somewhat different of what we saw in the psoriasis trials. And so when we look at infections and infestations, we have to counsel our patients accordingly that they may be at risk of infections. We see the rates of serious infections, although a very low, higher than placebo, but 0.2%. We do see some candida infections, which we saw in the clinical trials for psoriasis as well, and adjudicated SIB, and we're going to get into that in a minute as well too. But generally speaking, also looking at the hepatic events, we see them in placebo too, Jim. We see these patients with HS having changes in their transaminases, even at baseline, even in the placebo arm here too. And I think we can say, go ahead.
Transaminase elevations happen in people that are not on any therapy. Now, I'm not discounting that something can happen, but they happen. They took a drink the night before. They're taking some, whatever, or they just have an elevation at that particular point in time. So these are very low rates. We really didn't see anything here different than what we know from the psoriasis trials, quite frankly.
Yeah, and we from the standpoint of URI and headache, injection site reactions, tinea, even the candida as well, herpes simplex, and the majority of these treatment emergent adverse events were mild to moderate in their severity, and it was tolerated quite well with no new safety signals from that control period out to week 48. If we start to look at longer term data, and we look at 1 year, year by year, year 1, year 2, and now we start to look at per 100 patient years. First of all, we really don't see significant changes in terms of the safety from year 1 to year 2. And so we can have comfort in knowing that from year 1 to year 2, and even in comparison to the control period up to week 48, that the safety profile is rather similar. And in terms of the candida, which we've talked about a lot when it comes to IL-17 inhibition, and particularly IL-17A/F inhibition, that the majority of the candidiasis cases were oral candidiasis. They were mild to moderate in severity, and they were resolved recovering with standard antifungal therapy. And I think, Jim, is very, very similar to really what we saw in the psoriasis trials. The drug is indicated for the treatment of adults with moderate severe hidradenitis suppurativa. We talked a little bit about SIB. We know that BIMZELX, even as we saw and discussed previously with this package insert from the psoriasis data and an approval for psirosis.
And SIB, suicidal ideation, is not unique to BIMZELX, right?
It's unique. It's unique to psoriasis. It's unique to HS as a disease.
It's unique to life. Okay.
Yeah, but we don't see really differences here in the HS trials.
In people with these chronic diseases, you got to watch for it regardless of what they're taking and what they're doing. And
counsel accordingly. We have to screen for tuberculosis. We just talked a couple of moments ago about that infections, when you inhibit the IL-17 inflammatory cytokine, that mucosal preserving cytokine, a neutrophil chemotaxis, cytokine, you may get some infections, you may get some candidiasis, and we expect this potentially mechanistically. There were some elevations. We talk about the transaminases, which you can see in patients that are not on therapeutics. We can see this with other biologics, and we do. The rates of inflammatory bowel disease were quite low in the clinical trials, although we counsel our patients accordingly that IL-17 inhibitors in general may pose a potential risk. An individual who has a history of inflammatory bowel disease, this would not specifically be a therapy for them.
What's interesting in this package insert, avoid use when it's active.
Yeah.
It's not saying it's contraindicated if there's a history. You can decide on your own what you want to do with that. It says
no question.
When it's active, right?
Yep. Live vaccines administered before any immunomodulatory or immunosuppressive therapy, including BIMZELX, and the most common adverse reactions, as we know, URIs, oral candidiasis, headaches, injection site reactions, and those that we discussed in a previous slide. Convenient dosing, we alluded to this already, 1 dose every 2 weeks for 16 weeks, so it comes as a pre-filled syringe. More likely in my clinic, and as I've been using in my patients with psoriatic skin disease, an auto-injector, 2 doses equaling 320 milligrams, followed by, after the first 16 weeks, at every 2 weeks, every 4 weeks thereafter. And Jim, as we discussed, we need that, that loading dose. We need that saturation likely of those receptors. In terms of the access, I think UCB has done a great job in getting our patients this drug. There's rapid access, affordability for commercial insured individuals, about $5 per dose, $15 per dose when there's insurance coverage pending. There are nurse navigators to assist the patients and our clinics with the receipt of this therapy. And there's a My Navigate patient portal with savings cards for these individuals to receive their drug. And so to summarize, with BIMZELX, we see rapid response. We see individuals able to achieve high score 50. We saw that numeric difference at 22% between treatment group and placebo, high levels of efficacy beyond high score 50, 75, 90, and even 100, close to 30%, sustained control and improvement of abscesses and inflammatory nodules and draining tunnels just at week 48, close to a year. We discussed the pain reduction observed, 3 times increase in the numbers reporting minimal or no pain by week 48, improvement of quality of life. We went over substantially in looking at that high SQAL score, and a consistent safety profile, and consistent what we saw in the psoriatic disease trials. And with that, we hit it right at 8 o'clock, Dr. Del Rosso.
we nailed it. 5 o'clock my time, right? 8 o'clock Eastern time. And you know, I expressed a lot of enthusiasm, you know, because I've had an opportunity to see decent number of patients on this for a prolonged period of time, still in longer term extension follow-up. So it was very exciting to see these people do so well. And for us to have, hey, most of my career, I couldn't get patients better with severe alopecia areata, severe psoriasis, hidradenitis suppurativa. You know, people coming out now are blessed. You know, they don't know what those days were like. It's really, really exciting to see. You're only going to know if you give it a try yourself and learn it and use it and see what you think yourself. But I am very, very happy about this new approval, and I've been happy with the other approvals that BIMZELX has gotten. It really has been a great addition to our armamentarium.
I completely agree, and I feel fortunate to not only have these therapeutics in our toolbox, but more important, the potential success for the patients who really do suffer with this condition.
Good night, everybody. Thanks, Brad. Did a great job as always.
Thank you so much, Jim.
We have staying up to date with other webinars. On Tuesday, December 17th, we have chronic spontaneous urticaria, expanding spectrum of type 2 inflammatory diseases with Raj Chovatia. And I would imagine that Dr. Kircik is going to be on with that one, but if not, he'll find hopefully a better looking guy than myself to do it. And I believe that's the last slide, Ashley. I think that's it.
Yep, we're all set. Thank you all for joining us.
Thanks, everyone, and have a great evening.